Okay, I can't hear anything, but that might be
Oh,
okay. I'm having computer problems this morning.
okay. I know
Um,
Donna Johnston's on. Donna, can
I'll
you hear me?
figure
And
out my
I think,
audio after. But
okay,
as long
Rachel
as
heard
people
me,
can
so I
hear
think
me,
I'm
I
good.
think that's good. Um, so thanks, Eileen. Looking forward to your grand rounds. I want to start with the land acknowledgement. So Ottawa is built on unceded Algonquin Anishinaabe territory, and the peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia. We honor them in this land. Um, and it's a real pleasure to introduce Eileen, who I've run into at various points in my career, uh, um, and it's great that she's joined us at CHEO now. And she's joined us as the head of the Division of Hematopathology and Transfusion Medicine in the spring. She completed her medical school at U Ottawa, followed by residencies in pediatrics at Dalhousie, hematology oncology at Université de Montréal, and heme path at Dalhousie. She was the inaugural transfusion medicine lab director at Sidra Medicine in Doha, and the first women and children, which is the first women and children's hospital in the Middle East, and worked as a rural general pediatrician in Tignish. And a wide and varied career already. So she's passionate about the care provided to children, and I can attest to that. And areas of particular interest include teaching lab hematology and transfusion and the art of integrating the science of the lab into day-to-day clinical care, which is also a passion of mine, but from the biochemistry side of things. So with that, Eileen, I'm going to hand it over to you, and then I'm going to try and figure out how to fix my audio so I can listen in.
Okay, sounds great. Thanks for the introduction, and thanks for being here. I'm just sorry that it's only virtual and I won't get to see everybody in person, so I'll have to try to do this again another time or a different round so that I get to see people in person. So we are going to talk about transfusion medicine today, and there's a lot to get through, so I'll get started. I forgot to put a disclosure slide. I have no conflicts of interest or otherwise to declare. My objectives for today are to try to have, by the end, participants be able to order blood bank testing correctly and knowledgeably, to list compatible components for a patient's ABO and RHD type, to name the qualities and dosing of blood components that we have at CHEO and in Canada, and identify evidence-based guidelines for transfusion of red cells and platelets. And I clandestinely added one last little bit after you got the initial objectives, and that's because we have a new massive transfusion protocol or code transfusion at CHEO, and so I just wanted to outline a couple of the critical components of our new improved procedure. So I'm always envious of people who can give a great talk on the history of medicine. But I do think transfusion timeline is quite interesting, starting with transfusions of lamb's blood to humans back in the 1600s, right through to the description of the ABO groups, which is only in 1900. So it's not that long ago. First blood bank was in 1932 in Leningrad. RH was only described in 1939. We have tragedies, including the AIDS epidemic and contaminated blood, which I'll come back to in 1983. And in 2022, on a brighter note, CBS, or Canadian Blood Services, introduced pathogen reduction. So lots in between, but just to give you a sense of the last couple hundred years of blood transfusion. So it all starts actually with the sample. And the sample is really important, the pre-transfusion sample. And we have something in lab medicine called WIBIT, which is the wrong blood in tube. And this can occur because the wrong patient has a blood drawn with the correct label of the patient who was intended to be drawn, or the right patient is drawn and has the wrong label from a different patient. And we sometimes will find this in transfusion medicine based on looking at histories and having procedures in place to detect this. But this is an ongoing problem. And so there are several studies, including the BEST Collaborative, which is the Biomedical Excellence for Safe Transfusion Collaborative. They looked at 36 centers in 11 countries in the years of 2019 to 2020. And they were able to identify errors in factors such as labels being present when they shouldn't be. So if other labels or tubes are available at the point of collection, that is a potential for error. ePPID is electronic positive patient identification, which is barcode scanning of a patient's armband. So if that's not used or used incorrectly, and if samples are taken in an emergency department, those are areas where you would have increased risk of having the wrong blood in tube. And Jeannie Callum, who's a Canadian researcher out of Sunnybrook and now in Kingston, and colleagues identified a decrease in wrong blood in tube from 2006 to 2015. However, at the same time, there's actually an increase in transfusion reported errors in that time period. So it continues to be a problem. And in Canada, the reported incidence of ABO incompatible transfusion is 1 in 40,000. And that is attributed almost exclusively to clerical errors, so human errors in either the sample or the choosing of the blood and then the bedside administration. That can actually lead to death. And so these are hemolytic transfusion reactions which have led to death. This is reported from the FDA. And although the trend is certainly decreasing over time, you can see that in the last 10 years is quite a decrease. ABO incompatible transfusion, which is the dark blue color, continue to be reported annually with associated death. So in terms of the sample and trying to minimize these risks, we do have standards in blood banking. We have in Canada, the Canadian Society for Transfusion Medicine, or CSTM, has standards. The American Academy for Blood Banks, or AABB, which has changed names and I can never remember their exact name anymore, also have standards which are essentially pretty similar. And those are in an effort to prevent these problems. And so one of the standards requires that we have 2 samples at different time points to confirm a patient's ABO before giving ABO identical blood transfusion. So by blood, I mean peripheral, I mean packed red blood cells. And so there's a caveat that you can use a single sample if people use the electronic positive patient identification. However, that requires that your LIS system allows it, and it's a little bit more complicated than that to make sure that that actually works. Again, we know that electronic positive patient identification, if it's used incorrectly, is not going to be a source of safety. For red cells, over and above that 2 sample requirement, we do need a new sample every 96 hours for the screen part, which I'll explain in a few minutes. There are exceptions to that, including neonates and some preoperative. And depending on where you work, it'll be 96 hours, or depending usually on the LIS system, it could be, some people refer to it as 3 days, where day 0 is the day of draw. It depends if your LIS system allows you to count hours or has to count days. So just check with your center if you're not at CHEO. At CHEO, we do use 96 hours. For plasma, platelets, and cryoprecipitate, we do need a confirmed historical group. And by confirmed, I mean that second sample to be able to give type-specific product. So what are you going to order? Well, on TV, you would order a group and cross because the K sound is really satisfying, but it's actually not a group and cross that we want you to order. It's a type and screen. It's much more gentle and lovely, but that's what you really want to do. So what is the type and screen? It is a blood typing or group determination, which composes 2 parts. There's something called the forward typing or the red cell typing, and that is looking at what antigens are present on the patient's red cells. And in order to do that, we take the patient sample and we look at their red blood cells and we buy anti-sera that are anti-A, anti-B, and anti-D. And we test the patient's cells against the antisera. The reverse typing, or the plasma typing, is looking at what antibodies that we expect are present in the patient. So the patient's plasma against A and B red cells that we buy. And then the screen looks for other red cell antibodies. So the anti-A and the anti-B are what we call naturally occurring antibodies, and I'll explain that further in a minute as well. So we're looking for A, B, and D on the forward, but only anti-A and anti-B in the reverse, because anti-D is not naturally occurring. So this is what it looks like. This is my animation. The blood bank sample is usually a pink top tube or can be a purple top tube. It's an EDTA sample that when we receive it in the blood bank, we spin it down. We have red cells that are heavy, so they end up on the bottom. We take red cells, we put them in 3 different tubes. And then we add anti-sera, so we add anti-A, anti-B, and anti-D. We mish them around and we look and see if they agglutinate. And if they agglutinate, that should suggest that those antigens are present. So in this patient, the patient's forward looks like they're an A. So what should their reverse look like? Well, a lot of people don't know that you have naturally occurring antibodies. So before I show you the reverse, I just want to make sure everybody understands this. So after the neonatal period, we do have naturally occurring antibody. This is fun dinner time conversation. So how do you make these antibodies if you've never been exposed to blood? Well, our gut and our skin is colonized with bacteria. They make A and B substance. We self-tolerize to whatever we also have, but we don't self-tolerize to what we don't have. And we make these antibodies, usually starting at about 4 months of age. So they're, again, what we call naturally occurring. I will put out there that they're IgM antibodies. So they're very large antibodies. They cause direct agglutination in a test tube. And in vivo, they cause activation of complement and therefore intravascular hemolysis, which can be fatal. So IgM antibodies activate complement and they can cause intravascular hemolysis. That's why getting the ABOs right is so important. So this patient should therefore have anti-B antibody. So let's check their plasma. We put their plasma into 2 different tubes. We add A cells and B cells. We mix them around and they should agglutinate the B cells, which they do. This patient has a nice blood type of A negative. So in terms of the ABOs and D, just to bring it home again, A and B antigens are expressed on red cells. FYI, they're also expressed on platelets. And anti-A and anti-B are naturally occurring. Now you understand how we make those. RHD is expressed on red cells. Interestingly, it is not expressed on platelets. And anti-D is not naturally occurring and does require exposure to the D antigen, usually through blood transfusion or pregnancy. So what's this? So that was the blood type. Now we're going to get to the screen. So this is the screening cell. So when we're screening for unexpected red cell antibodies. So this is, some people call this for the minor red cell antigens, or their minor groups. And so they're not necessarily minor, like not important, but they're just not ABO. And so these antibodies, generally speaking, for your purposes, you can think virtually all the time, require exposure to red blood cells, again, either through transfusion or pregnancy. And when you make these antibodies, you start by making IgM, but you class switch to IgG, which is sort of this immunologic phenomenon that many of you will be aware of, where you class switch to IgG. And this is the principle of this testing. It is what we call IAT, or indirect antiglobulin testing. We're looking for IgG antibodies here. And so a negative screen would be the panel on the top, where we test the patient's plasma against 3 different red cells. And if it's a negative antibody screen, that really rules out the vast majority of clinically significant antibodies. If, however, as shown on the bottom panel, the patient reacted to 1 or more of these cells, as indicated in the second row as a 2+, this is a positive antibody screen, and we can no longer rule out the vast majority of the significant antibodies. So we have to go on to do what we call a panel. A panel is really time consuming, and it's what I call blood bank Sudoku. And so there we look at multiple different cells. We add the patient's plasma to all these cells, and it's a very manual process of ruling in and ruling out antigens to try to figure out what is the antibody. So that is the antibody screen. So why did I say we don't necessarily do a cross match? This is a little bit of a funny cross match, but what is a cross match in blood banking? Well, first of all, a cross match really only refers to red cell transfusion. And in modern days, it can be computer or serologic. At CHEO, we do computer cross-matching, and there are rules that are standards that we have to meet in order to do the computer cross-matching. But basically, it's based on ABO and RH matching tables that we have in our LIS system that we have validated to show that we cannot accidentally, that our computer system will not let us give something that is dangerous. There's no actual mixing of the donor cells with the recipient plasma. It's the computer that does the magic. So it's extremely quick because it's just the click of a button. Serologic cross-matching, on the other hand, actually requires time because you have to take the donor cells and the recipient plasma and look to see if there's a reaction. This is required in patients who have a history of antibodies or who have a positive antibody screen, for example. Once we do the cross match, we are assigning that unit of blood, that unit of donated blood to that patient. So the unit in the inventory is not available to anybody else now. And if we were to cross match for everybody, our fridge would be full of reserved blood that we couldn't give out. And so there's risks of outdating it. And so we don't do that. So if you accidentally ask for a cross match when you don't actually know that the patient's going to need a transfusion, we switch that to a screen. So that's what the cross match is. So it's important to understand what uncross-matched blood is. And so uncross-matched blood is given if we don't have a current type and screen result, for instance, in an emergency situation. And at CHEO, we will only give O neg or O positive, depending on the gender, uncross-matched red cells. We only will give type-specific uncross-matched blood after we've done the blood type twice. So we have to either have a previous history or twice on the current visit before the antibody screen is released. So what's the risk of uncross-matched blood? I find people are frightened of uncross-matched blood. They're worried that somehow it's, I don't know, dirty or got infection or something. The risk is of hemolysis, but from non-ABO antibodies. So they're IgG antibodies. IgG antibodies cause extravascular hemolysis through splenic macrophages that recognize the FC portion and eat up the red cell. So it's mostly delayed extravascular. This occurs in about 1 in 7,000 transfusions. It is not generally fatal, but you can get pretty yellow with it and a little bit of anemia for sure. But it's relatively low risk. And again, if the patient has never had a transfusion, their risk of having a non-ABO antibody is virtually zero. So again, in an emergency situation, uncross-matched blood shouldn't frighten anybody. We are required by standards for the transfusion physician to or practitioner to sign that they understand that it's uncross-matched. In my experience, I have sometimes, if I have given the education at the time of transfusion, if there's someone who doesn't understand it, I will sometimes sign for it. But I try to provide the education in a kind of in the moment if somebody doesn't really understand what the implications are. So we know that people learn in many different ways. And so I have a couple of different ways of showing you the red cell compatibility. So this is the compatibility table where I'm showing you that the group A red cells have the pink antigen, they have the anti-B antibody. The group B has the anti-A antibody, AB, no antibodies. And group O, we have all the antibodies. We've got all the A and all the B, and we are all up in everybody's business with our antibodies. So then, if I show you this way, because it's a little bit more fun, can we give A red cells to an O recipient? So the O recipient denoted by not having the A on their cells. So if I transfuse A red cells to an O recipient, they have IgM antibody and will cause intravascular hemolysis and potentially very severe morbidity and even death. Bad idea, please don't do it. On the other hand, if we want to give group O, you guys hear it on the radio all the time, there's a need for group O donors. Well, because group O red blood cell donors are universal donors, we can give group O because there's no anti-O antibody in the A recipient or the B recipient, for example. What about D? So D is interesting. There's no antibody. So the first time round, if we give a D positive red cell to a D negative recipient, they'll be good, happy, joy, joy. Problem is they will likely make an antibody. So they've got a high chance, it's an immunogenic antigen. They will often make an anti-D antibody. That antibody, however, if you give the D the second time, will be IgG, and the spleen will cause a hemolysis, so extravascular hemolysis. You will have detected that anti-D antibody in your screen. So that's where you find the anti-D antibody if someone has made it. In which case, you probably wouldn't give them D positive cells. So another way to look at red cell compatibility, looking at the recipient versus the donor, what is compatible, who's compatible with whom. And again, the asterisk denoting the Rh, which we can give the first time around, but the second time we wouldn't. And at CHEO, we don't give Rh positive red cells to Rh negative females of childbearing age because of the implications of making anti-D in a future pregnancy. Males, however, can receive Rhd positive cells. So another way to look at it, universal donors, O can give to everybody, AB really can only give them to themselves. Okay, so speaking of O donors, I just love the internet, and I thought I would put on a couple of these funny things, but you can date by blood type, just, FYI, in case you're interested. People with O are fun and supportive, if you didn't know. So I happen to be O. But anyway, I do communication and teamwork based on trust, but I suspect non-O people do the same. Okay, on to plasma. So plasma is basically a product. So when I'm talking about plasma, I'm talking about the plasma product for transfusion. So the plasma is full of antibody, right? It's got antibodies, it's got coagulation factors. We're not giving it because of the antibodies, we're giving it because of the coagulation factors generally, but the antibodies are there. And so if I tried to give group O, that universal donor, group O, to a group A recipient, but I gave the group O's plasma, the plasma would cause hemolysis of the recipient red cell. And so again, intravascular hemolysis from IgM antibody, bad idea. Causing hemolysis in the recipient is bad. If I give 250 mils of plasma to a 70 or 80 kilo individual, the amount of hemolysis might be relatively mild. However, if I do that to a smaller blood volume patient, it can be very significant. And even in the big person, it's still there's still significant hemolysis. So on the other hand, if I want to give group A plasma to a group O individual, that's no problem. There's no anti-O antibody in the A individual. So that one works. So another way to look at plasma compatibility, and this is my reminder, the asterisk, is that there are no cellular components in plasma. So Rh does not figure because remember that the donors don't have anti-D antibody, so we don't have to worry about anti-D antibody. If somebody happened to have an anti-D antibody and they were a donor at Canadian Blood Services, that would be flagged and their plasma would not be able to be used for the purposes of transfusion. We'll go to a fractionator. So for your purposes, plasma is labeled as O, A, B, or AB. We don't label it with Rh at all. It's completely insignificant. So the universal plasma donor is AB because they don't have any antibodies, right? Okay, so that's plasma. And then the most difficult is the platelet compatibility. So platelets are a bit more complicated, and they're complicated because you have to use rules for both the red cells and the plasma. That's because platelets, as I said earlier, express A and B antigen. And also the platelet product is suspended in plasma. Red cells have very, very, very little plasma in the bag of red cells, but platelets have quite a bit because platelets are tiny, and if we didn't put them in a bunch of plasma, they would stick together, and that would be useless. They would just get caught in a filter. So they have to be swimming around in this relatively large amount of plasma. The products in Canada now have smaller amounts of plasma for the most part. So at CHEO, it's a relatively small amount of plasma because we have platelet additive solution. Different centers may have different products, and you would need to understand that depending on where you're practicing. The platelet product can have a small, tiny amount of contaminating red cells just from the production method. And the red cells that are in that product will have the RHD antigen if they're from a D positive donor. And those small little amount of red cells can cause sensitization and development of anti-D in an Rh negative recipient. So the Rh with platelets matters because of the tiny bit of red cell contamination. So if I show you that in a picture, group A to group A, sure, that's type identical, there's no problem, everything's happy, the recipient's red cells are happy, the donor platelets are happy, great. If I try to give group O platelets to a group A recipient, what could possibly happen? Well, the platelets are fine, but there's plasma, and that plasma can cause some hemolysis. So can be a problem. Again, we would never do that with plasma. We wouldn't give O plasma. The reason you have to understand this is because platelets are only good for 7 days. And managing 7 days expiry of a product is really challenging. And a lot of people say, well, doesn't the blood bank just give us the right type? They do when they can, but sometimes they can't. So with red cells, we can. They're good for 42 days. We can manage that inventory. Plasma, it's good for a year. We can manage that inventory. 7 days becomes pretty unmanageable, and we don't necessarily have the exact type of your patient. So that's why you need to understand this. Okay, so that was what we call a minor mismatch. Doesn't mean minor harm. That's the technical term for the type of mismatch. This is a major mismatch where the group A donor is going to a group O recipient. So what happens? There's no antibody against recipient red cells, but there are antibodies. Oh, where did those platelets go? So the antibody is against the platelet, and we don't call that hemolysis because we don't break apart a platelet and have hemoglobin leak out. But what we do is we get rid of the platelet more quickly. And so you can have a decreased response to your platelets and decreased platelet count that you were expecting your platelet count to go up by, say, 30. It might only go up by 5 because you cleared them so quickly because there was antibody in the recipient. So in summary, for platelets, they should be type specific. We strive to do that wherever possible, but it's not always possible. In fact, it's often not possible. Remember that the anti-A and anti-B in the transfused plasma component of the platelet can cause hemolysis. When we give plasma incompatible transfusion, there are rules, and at CHEO we do look to give what we call low titer product. So they have low titer of antibody that as measured by Canadian Blood Services. So that minimizes that risk, but it's not zero. The anti-A and anti-B in the recipient can decrease the response to platelets. And the D antigen that's present on the red cells in the platelet component can cause alloimmunization. So that's what you need to remember about platelets. So what is your type? So this is just a map of blood types in the world. In Canada, we have a predominance of O and A blood types. As shown on the right, that's the data from Canadian Blood Services. So 39% of the population of Canada, or donors anyway, is 39 O positive, and 36% are A positive. Rh negative is a much smaller number of patients. You see that 7% are O negative, which would be the kind of true universal red cell donor. And AB is only 4% if you combine the AB positive and AB neg. So for AB plasma, really small amounts available in this country. So now that you hopefully understand the ABOs and the Ds, we'll go on to the products and the products that we have in Canada. So when we talk about blood products, there's a little bit of semantics here, and we call blood components those that are made from whole blood or apheresis donations, which are the ones I'm going to talk about today. Blood derivatives, or some people call them blood products, the nomenclature has changed, and we now call them plasma protein and related products. They're manufactured from or with blood components, for example, IVIG. So the blood components that I'm going to talk about today are packed red blood cells, platelets, and plasma. I'm really going to just ever so slightly touch on cryo, but not for very long, and I'll explain why. In Canada, the components that we have are anticoagulated with CPD or ACD. And the C is the most important part there because there's citrate. And remember that citrate is a calcium chelator, and calcium is required for blood clotting. And so if you give people a load of citrate, they will get hypocalcemic. And so it's important to remember that every product that you give has citrate in it. And if you give a lot of product, you're going to chelate even the patient's calcium. All products in Canada are leukoreduced and therefore what we call CMV safe. So I just thought I would show you what I would call the lexicon of blood products. So I'm often asking people, where do you go for information if you want to order a blood component? And people say, oh, I don't know. If you were going to order amoxicillin or you were going to order chemotherapy, you would look at that drug in a monograph. You would look for some kind of drug monograph somewhere to figure out your information. But for blood components, people don't know where to look. So I thought I would show you because it's not so obvious. Blood.ca is the site of Canadian Blood Services. And right here under hospital services at the top, if you click on that, then when you get to hospital services, on the bottom in red writing, there's a one that says products. I think my little square went to the wrong place, sorry. Under products, there's a component types. That's where it keeps coming up. Under component types, there's something called circular of information. And then you have the circular of information for each different product. So for red blood cells, for instance, which is the first one listed, this is the circular of information. Each one of these circulars of information are 4 pages. The second, their last 2 pages have all of the current risks of transfusion. So it's a really helpful document. They do update them. This is the most recent update from April of this year. It includes the volume of the product, the manufacturing details, so what the hemoglobin is of the unit, what the residual leukocytes are, for platelets, what the platelet count would be. It goes through a little bit on indications, not very much, any warnings and precautions, and tells you what else is in the product. For instance, in red cells, the additive solution, it goes through that. So packed red cells, there is an additive solution. It's like a feeding little mix to keep the red cells to last longer. So it's in Canada, SAG-M, or saline, adenine, glucose, and mannitol, is about 110 mils in the unit. The hematocrit of the unit is about 67%. So that's why we call it packed cells. It's higher than our own hematocrit. The mean unit volume in Canada is about 290 milliliters, give or take. There's only about 30 mils of residual plasma. The shelf life is 42 days. The dosing is 10 to 15 mils per kilo to a maximum typically of 1 unit. Platelets consist either of buffy coat pools or apheresis, which is single donor donations. The buffy coat pools are either 3.5 or 4 donors, depending on the product. They may or may not be pathogen inactivated by sorolin, which incidentally replaces irradiation. Sorolin treatment of platelet products in Canada, that is what we have at CHEO, by the way. The sorolin is added to the platelet product and exposed to UV light, and then the sorolin is most of it is taken away, bound, and that is because the sorolin and the UV light cross-links DNA and RNA, and so even if there was a microorganism that we don't know about, that hasn't been tested for because we don't have a test because we don't know it exists, the idea being that this would cross-link that DNA/RNA, and therefore the microorganism would not be able to replicate. And so it is an added layer of safety to the blood system. We also have platelet additive solution now, which makes the expiry of platelets 7 days. And I told you that's hard to manage. We used to only have 5 days. So if it doesn't have platelet additive solution, it's only 5 days from time of donation. So the 2 extra days really makes a difference for us. And then, so each volume can be quite varied, 180 to 315 mils, depending on which type of product we have. The dosing is about 10 to 15 mils per kilo to a maximum of 1 unit. The platelet components of Canadian Blood Services, so this can be a bit confusing, but there are pooled platelets that are leukoreduced in CPD and apheresis. Those ones are not sorolin treated, and they do not have PAS or platelet additive solution. The 2 that we have at CHEO are the pooled platelets that are sorolin treated and do have PAS, or apheresis platelets that are sorolin treated and also have PAS. There's also apheresis platelets that have PAS, but not sorolin treatment. So those are the details of the ones that we have here at CHEO. Plasma can also be derived from apheresis donors or from whole blood donors. So they call it frozen plasma. It's not frozen when we give it to you guys, so I just call it plasma. Each unit volume is about 250 to 290 mils. I told you already that the RH was irrelevant, so we don't, is not labeled as such. It does require modification, so we get it frozen. It's hard as a rock, and it takes us about 25 to 30 minutes to thaw. So that's an important one. We do not keep thawed plasma here on site. They do at the general. they keep AB thawed plasma. You can imagine with the small number of AB donors that wasting, once plasma is thawed, I should mention, it's only good for 5 days. And so we don't want to waste that plasma for sure. The dosing, again, 10 to 15 mils per kilo, usually to 1 unit. And I'll come back to that. We also have solvent detergent treated plasma, or SD plasma. So this technically falls under the plasma protein related products. It is manufactured by a company. The product that we have is called Octaplasma. It's about 200 mils per unit. Still has the same ABO requirements. Cryoprecipitate is not used very often and was typically used to give fibrinogen. We have moved to using fibrinogen concentrate, and Canadian Blood Services will be stopping manufacture of cryoprecipitate. And so it will no longer be available at some point in the not too distant future. So that's why I haven't gone through the dosing of that. We're really moving towards using fibrinogen concentrate. So now you know the ABOs. You know what products we have in Canada, and so then you have to decide when you're going to transfuse. Really, you're going to transfuse when the benefit outweighs the risk, when alternatives are not as safe, or alternatives are not practically available. So there are evidence-based guidelines, particularly for red cells, platelets, and plasma. Not much in the way of evidence. So here I want to just put a little mention of the tainted blood scandal in Canada. So those of you who were not of age to remember this in the 80s, there was a time in the 1980s, back when the Canadian blood supplier was the Canadian Red Cross, where the testing for HIV and hepatitis C was delayed. And in that period of delay, there were many hemophiliac men and their partners who were infected with HIV and hepatitis C. And this is the frequency of HIV in the US hemophilia birth cohorts. So you can see in 1978, the HIV percent positivity was 45%. And this is the survival curves of HIV positive individuals with hemophilia in Canada. We killed many of these men, and it was a huge tragedy. And this is from the Canadian Hemophilia Society. And really, the tainted blood tragedy is one of the worst public health disasters that Canada has ever faced. So it's very sobering, and the safest transfusion is the one you did not get. So although I love blood bank, I love that blood can save people's lives, you should only give it when you absolutely need to give it. So in terms of red cells, the studies, there's some seminal studies out there, the Transfusion and Critical Care trial, which looked at a restrictive versus liberal transfusion strategy. So transfusing patients when they had a hemoglobin of less than 70 versus less than 100. There was decreased mortality in the restricted group. The TRIP ICU study was the pediatric correlate to that study. So transfusion pediatric intensive care. There it was a 70 versus 95 trigger, and there was no difference in mortality or adverse outcome, but there was fewer transfusions in the restrictive group. The PINT is the premature infants in need of transfusion. Again, no difference in mortality or severe morbidity using a restrictive versus a more liberal transfusion strategy. There are other studies out there, but these are the sort of 3 that I like to mention. There was also a recent guideline that is the TAXI guideline, so the Transfusion Anemia and Expertise Initiative. And so this is available in this Pediatric Critical Care supplement, and it goes through sort of children in critical care, because that's where the literature is in the critical care setting, and looking at different clinical scenarios and what one would consider for transfusion triggers in terms of hemoglobin level. And they do grade the evidence and go through a Delphi consensus for situations in which there is lack of evidence. So it's a really great resource, and I would encourage you to have a look. This is the summary in a very quick Coles note version. So in critically ill children, if the hemoglobin is less than 50, transfusions generally recommended. And I would put an exception there of iron deficiency, where what they need is iron, not necessarily red cells. A hemoglobin of 50 to 70 is that one would consider transfusion based on clinical judgment. Again, that's an expert opinion. Hemoglobin greater than 70, do not transfuse. The caveat to there is acute brain injury, some oncology patients where we use 7 to 80, and sickle cell anemia, as well as uncorrected congenital heart disease. So a few little caveats, but the details are in the notes. So generally speaking, for kind of the majority of our patient population, hemoglobin of less than 70 and symptomatic. That doesn't mean a kid with iron deficiency who's tachycardic. That's compensation and is normal. It's almost never right to give a transfusion in iron deficiency. The exception is an acute on chronic blood loss, potentially. Neonates really depends on postnatal age and their level of respiratory support. And so the numbers, I would not rely on the 70 and look in the details there. Thalassemia and sickle cell, a little bit of a different situation. And in massive transfusion, we aim for a hemoglobin closer to 80. So that's red cells. People ask about CMV for red cells. Leukoreduction is considered CMV safe. There might be an exception with intrauterine transfusion, and pathogen inactivation, as I mentioned, also renders CMV inactive. So that's an extra layer of safety when it comes to platelets. For irradiation, this is a busy slide, but I will be reviewing our guidelines for transfusion here at CHEO, and this will be included. This is the National Advisory Committee on Blood and Blood Products current recommendations for who should get irradiation. Irradiation of red cells and platelets when needed is to decrease the potential for transfusion-associated graft versus host disease, which can occur in patients whose T-cell immunity is hampered, or if they have HLA-matched components. So I'm not going to go through each of these indications, but I do think it's important to understand them. For purposes of ease of use, sometimes there are places that will just give irradiated products to, for instance, all oncology patients. But that's mostly because if we don't have the good communication of knowing which patients meet these criteria, and if people don't know the criteria, the safest thing is maybe to irradiate. However, irradiation is not without adverse effects, including damaging the red cells and causing a potassium leak, which can be significant. For platelets, this is what we use right now at CHEO. Again, given that I'm new, I get to revise everything and maybe put my 2 cents worth in. And there are some new, little bit of new literature out there that we can use. But these are the guidelines we currently use. And so I wouldn't ask anybody to do anything different than what's out there. But in terms of the evidence for platelet transfusion in children, there's really not a lot. This was one of the biggest studies, which is the Play-Doh study. And it actually was not about do you give platelets or don't you, but more what is the dose that you give? And so there's no difference in bleeding with doses anywhere from 1.1 to 4.4. So they looked at giving sort of a pool of 4 units, a pool of 6 units. They really looked at all these different doses, and there's no difference. Just to give you an idea, I translated in for our products here in Canada, these are the doses that we have, somewhere around the 2 to 2.5 to 3.5 times 10 to the 11th per unit of platelets. So 1 unit should suffice. You don't need to give 2 units, even if the patient's weight is above that. There's no evidence that it helps. I forgot to mention there was a study done on this exact group to tease out the bleeding tendency of children, and what it did show was that children have higher amounts of bleeding. So greater percentage of children have what they call grade 2 WHO bleeding, as well as more days with that clinically significant bleeding than the adults. And so we typically, I see something's coming in the chats, I'll answer those after. So that's really what we have for evidence. Other than that, it's mainly expert guidelines. For plasma, this is our current, which I'll show you where to get it online, indications for plasma transfusion. It's typically multiple factor deficiency, so in the context of, say, massive transfusion, or sometimes in a plasma exchange situation. In terms of the evidence, yeah, nothing. I got nothing for you, people. There's really essentially nothing out there. Sorry. Fibrinogen, so cryoprecipitate / fibrinogen. So this is the replacement. There's some evidence in a massive transfusion for sure, but other than that, again, I can't show you great evidence. It's expert opinion by and large. So we decided to potentially give transfusion. I'm just going to quickly touch on massive transfusion at CHEO. I know you can't see this entire algorithm, but it is available in the new code transfusion procedure, which I will show you where to find. And this is really just the cheat sheet. But the code transfusion, as far as I'm concerned, the most important part is communication. That is the key. It's really important to streamline communication with the lab or transfusion medicine and transfusion medicine. It does decrease time to obtain product. It identifies roles, standardizes an approach, decreases product wastage, and having a protocol has been shown to decrease mortality. So we need to have a protocol. We need to have a good protocol. Our protocol really places a lot of focus on roles and responsibilities. And so section 6 is the roles, and we identify different roles and give them names. And this picture is, I got your back. And when someone is managing a massive transfusion, to have the transfusion medicine physician, for instance, being able to be their backup in the lab and do that liaison can be life-saving. The pearls that kind of I'd like you to take away when you look at it: tranexamic acid within 3 hours of injury, use lab-guided transfusion, which is on the right-hand side, and anticipate and manage complications. I know you won't be able to see the details of the complications, but that is available on the back of the appendix that has the algorithm on it. So how do you find TML info? We're on the 3rd floor in the lab. My door is always open, except that I'm giving a talk. That's why it's closed today. But usually my door is always open. You can find information online as well. So if you go to clinical teams and programs on CHEOnet under ERLA reference lab, then there's a transfusion medicine and infusion therapy page. There's some really great resources here. Our component transfusion guidelines are the very first one at the top. There is a link to the new massive transfusion procedure, as well as just the algorithm. On the bottom right, in website links, there's links to the Canadian Blood Services circulars of information. It's a little bit easier to get to. Roxanne's put a lot of work into this, so a shout out to her. This is your transfusion medicine team. We have our lab director, Ivan, our lab manager, who was Patty, is now Nadia, so welcome to her. The heme paths are me and Mira. The techs, Roxanne, and I did this in alphabetical order because I don't love anybody more than anybody else. But your transfusion techs are phenomenal and very dedicated to your patient. So thanks to all of them. And I just had to leave with one more joke because I just thought it was so funny when I was trying to find something. You can even eat for your blood type. So my blood type is O neg, and I think probably chocolate is the right thing for O neg people. So I usually have chocolate in my office too. So anytime people come visit, please be a donor if you can. So Canadian Blood Services always needs donors. And if you're able to donate, I would certainly encourage you to do so. You can go online or 1-888 to donate to be a blood donor. It's a life-saving. Any questions? I will look at the chat now and see if I can answer anything, or see if Pranish wants to mediate that.
Yeah, so thanks, Eileen. That was great. I fixed my audio, and yeah, in the chat it was just the evaluation link and positive feedback thus far. So so I see Donna has her hand up, but before, I just wanted to comment from a biochemist's point of view that I first learned about the AVO blood group really because they're O-linked oligosaccharides with a different glycosyl transferase activity that's variant dependent. And so I learned about it in detail in trying to figure out how you actually interpret urine oligosaccharide profiles, which I found fascinating, and that these are actually, what the actual antigen differences are. So anyway, that's just a little curious side tidbit. This is we think of it in the blood group, but it does have, with your diet kind of thing. I don't know, how evidence-based all that is, but there are, significant differences in those cell surface antigens that are tied to the oligosaccharide tree. So anyway, there's always a biochemistry angle to everything. But Donna, you have the first real question.
Thanks. I will just make a comment that Emanuela put a comment that she's B negative and chocolate's her favorite, and I'm A negative and chocolate's favorite. So I think the chocolate goes with the negative, not the A.
Universal.
No, I'm all positive and I like chocolate too.
That was my question. So my question is about, Eileen, when we order platelets, which we do a lot in oncology, and we are giving the RH doesn't match, we're asked to give Winrow, but I haven't been asked for a long time. So I'm just wondering if you can touch on if you're giving a negative, positive platelets to a negative patient and the use of Winrow, and are we still doing that?
Yes. So absolutely. And then there's a question on the chat that I'll answer in a second. So yes, and Canadian Blood Services still recommends it. The Buffycoat pools have more red cell contamination than apheresis. Apheresis product really do have very, very, very little. And there are some institutions that have not, that say that it's so little that you don't need to prophylax with anti-D, immune globulin or Winrow. I think there's still a little bit of a risk, and the Canadian Blood Services Circular of Information still recommends it. So yes, we do recommend it. And so that is to mop up those few little red cells that are remaining. So if we give an RH positive platelet to an RH negative recipient, we do recommend giving RH immune globulin. And I'm trying to work out a system. So I think we do catch them in the lab. And I'm trying to work out a system so that it's a bit more clear and so that I can put a comment so that it's really obvious on your end and in Epic. We usually give a single dose and it lasts usually about 6 weeks. There's a half-life, but every time we do the antibody screen, we can see the anti-D. So we know if it's still around. So we have one patient who just recently lost it. Yes, so the answer to your question is yes, absolutely. I would still recommend we give anti-D immune globulin.
Yeah. Great. I'm going to give you the trivia that to go with Pranish's, as you brought this up. So Winrow, does everyone know it's called Winrow?
Winnipeg.
Discovered in Winnipeg. It's a Canadian thing, and just to highlight little Canadian.
Exactly. So we like to say Winrow, not Rogam. In fact, we like to say anti-D immune globulin because we try not to support pharma. But anyway, the other question on the chat was, can we do an AVORHD alone, or does it always have to be with the antibody screen? Absolutely. We can do a blood type alone. So you can just order an AVORH and we will just do the blood type. We don't need the antibody screen. So that is an orderable in Epic that you can order, and we will do it on its own. Yes.
Eileen, there's another question in the chat from Rasheen. Is there a good resource of providing good quality informed consent for various products, e.g. packed red cells versus platelets versus IVIG? I've been unable to find this.
Yeah, so for the blood component, so for red cells, platelets, I think using the circular of information for the risks of transfusion is probably appropriate. Ideally, in a perfect world, when I have a little bit more time, it would be nice for us to have our CHEO-ized information for blood components. It's quite different. The risks of blood component therapy and the risks of protein product and related protein, plasma protein and related products is a little bit different. So the IVIG the risks are quite different. And so I'd probably separate those out, but I don't know of a really easy to find resource. I've typically created them where I've worked. Is it possible to have the blood product consent as a form in Epic that we live on the patient's chart? I don't know the answer to that, but I'm going to screenshot that. And I tell you, so that was Dr. Langevae's question. I'm all over improving the LIS piece, like all over it. And so it's a big project actually, but we've got a few things that we're trying to work on in transfusion medicine to give you value added. Donna is saying in oncology we scan it in, so it's under media. so much easier to complete when in the room with the
Yeah,
patient. Agreed.
it's more about the, like,
Yeah.
you're seeing the patient, you're telling them about the transfusion. You could then, like, if you could
Yeah.
fill it in and
And they
do it
could
there,
electron-
and then, yeah, it would then be electronically done. Yeah.
Yeah, I will bring that back to my IT folks as this is a more patient-centered and team-centered approach and see what can be done. There's some other things, I'll be honest, Melissa, that probably are higher on my priority list, like making sure you can actually see all the transfusions that have been given, because right now you can't, if little details are missing. So I got to work on those things. But that's another really good one for us to work on for sure.
Yeah, thanks. Eileen, I have another question. I mean, we're in Ottawa, right? So we live on the Ontario-Quebec border, and we have Canadian Blood Services and HIMA Quebec. And I'm just wondering, does that present any issues or challenges? I'm thinking about patients who might be on the Quebec side, having some care here, having some care in Quebec. Is there information sharing between those two agencies? Is it a thing? Is it not a thing?
So yeah, so Canadian Blood Services services every province except Quebec. We're HEMA Quebec, and that is historical from when the Red Cross was dismantled, and is a direct result of the whole tainted blood scandal, actually. And HEMA Quebec has some different abilities that we don't have. So they have a trace line, which is provincial, and their communication of their blood bank information is in my opinion better in Quebec than it is in the rest of Canada. We have quite a good relationship though with HEMA Quebec, and so we get in touch with them for various things. So we have patients who in oncology might be treated at Saint Justine, and so we will give back and forth information, and that's been not a problem that I'm aware of at all yet. I would say just people sometimes don't understand that if you already had a blood type done somewhere else, we don't accept that here. And so we don't, we have to do it here. We cannot accept a blood type that was done, say, in Gatineau, and then say that's correct. And the reason behind that is that whole sample issue and that mislabeling. And so that's the one caveat. We don't share that information. Even if it was done at TOH, we still can't believe it here. We have to do our own. That's part of standards.
Yeah, no, thanks, Eileen. And I was thinking maybe specifically about those patients who have frequent transfusion, have multiple rare antibodies, you know, where, and if there's is there any risk to consideration across those provincial because of the two systems? But
yeah,
sounds like that's not the case.
No, it's pretty good communication, and our senior technologist Roxanne Labelle is pretty on top of that about getting any information that we need. So it's great. And the other thing is really empowering and improving the health literacy of the patient and their parent so that they're aware. So if we identify an antibody here, we provide an antibody card with a bit of an explanation to the parent. The first one, in fact, that I was involved with, Roxanne and I got to go down to the bedside and tried to explain it to them, offered to explain with the other parent if they had any questions, that kind of thing. So we're trying to make sure that they're also empowered to make sure they understand when they have to give that information. Yeah.
Great. So thanks, Eileen. We're at time. For anyone interested, I pasted a cartoon of the actual oligosaccharide tree and how it differs between A, B, and O. And I think that was great. And I also, the mandatory training has the transfusion module, and this was really helpful to fill in some of those gaps as well. And I really do enjoy the transfusion module, but this really filled a different need. So yeah, thank you again, and look forward to Grand Rounds next week.
My pleasure. Take care, everybody. Have a great rest of the day.
Bye.